And so we will jump very quickly into the business of the day. I'm very privileged to be introducing two very seasoned professionals and experts who have extensive experience and are extremely qualified in this field that we're discussing today. I will start by introducing one of our speakers, Dr. Dike Ojji, who is an associate professor of preventive cardiology at College of Health Sciences, University of Abuja. He's an honorary consultant physician /cardiologist at the University of Abuja Teaching Hospital here in Nigeria. He is a lead investigator and he's a cardiovascular research unit. He has worked extensively with multiple partners across different projects and different investigative work in healthcare. He is a graduate of University of Ibadan. According to Dr. Dike Ojji, he says that there are only two universities in Nigeria, University of Ibadan and the rest. He also has a postgraduate training in internal medicine and cardiology at University College Hospital Ibadan and Royal Brisbane and Women Hospital Brisbane in Australia. He holds a Ph.D. in cardiovascular medicine, I beg your pardon, from the University of Cape Town, South Africa. So you see, when I say that our speakers have extensive experience and are very qualified, I was not just saying that. He is a fellow of West African College of Physicians, African College of Physicians, Nigerian Cardiac Society, and European Society of Cardiology. He's a practicing cardiologist, researcher, and teacher, and he's interested in global cardiovascular health epidemiology, especially in the Black population, which I believe most of us on this call serve that particular population. His work spans through a large spectrum of different areas: hypertensive heart disease, hypertensive heart failure in Black population. He has been involved in a number of multinational observatory and clinical trials. He has over 95 manuscripts in peer-reviewed journals, and he is married with 2 children. We send a very special welcome to Dr. Dike Ojji. We also have with us another very seasoned professional and expert with years of experience and expertise. We have Dr. Okechukwu Ogah on the call with us. He is our speaker as well. He is a senior lecturer in cardiology at the Department of Medicine, University of Ibadan, and consultant physician / cardiologist in the Division of Cardiology, Department of Medicine, University College Hospital, Ibadan. He holds a PhD in medicine from the University of the Witwatersrand in South Africa. So there's something about the two people that we are hearing from today. They both went to the only university, one of the only universities in Nigeria, and then they have also done some training outside Nigeria and other African countries and other countries of the world. Dr. Ogah is also he's also a fellow of the West African College of Physicians, Nigerian Cardiac Society, European Cardiac Society, and American College of Cardiology. He's a Bernard Lawn Visiting Scholar at the Department of Global Health and Population in the Harvard School of Public Health, and is the current president of the Nigerian Cardiac Society. His research interests include surveys on cardiovascular risk factors, national heart disease registries, continental heart failure registries, pericarditis. He has over 120 publications in peer-reviewed journal, and he is also married with children. Please welcome very warmly Dr. Okechukwu Ogah. So for today, we will be having the didactic for 30 minutes. Dr. Okechukwu Ogah will be starting off, and then Dr. Dike Ojji will take over. Over to you, Dr. Okechukwu. Sir, can you hear us?
Thank you. Adora, for the kind introductions. We're very grateful. Thank you for inviting me as a speaker. Very, very fast to speak on this program. Um, I'm very grateful. So please, can we move on? The next slide, please. Can I have the next slide? Okay, the next, please. So the objective of this lecture is just to understand the practical approaches that are necessary to obtain accurate blood pressure measurements. And secondly, to understand the various hypertension diagnostic categories, as well as the therapeutic implications. So next slide, please. So what is high blood pressure? High blood pressure is the same as hypertension, although some people may say they are not the same, that your BP can be high and it's not sustained. You need to take it at least on 3 or more occasions, and once it's sustained, then we can classify it as hypertension. And in the layman's language, we usually take these two as the same. It is the force of blood as it presses against the wall of the arteries of our body, while it moves to supply oxygen and nutrients to other parts of the body from the heart. Next slide, please. So when we measure blood pressure, doctors or nurses or health workers, they usually give you two values. There's usually an upper value, which we call the systolic blood pressure, which is the force that the heart generates in order to transmit blood to various parts of the body. And then the lower one is the lower blood pressure, which is the pressure when the heart is in relaxation. And these are the two things we record when we measure the blood pressure of an individual. The systolic blood pressure, which is the same as the pressure when the heart squeezes, and then the diastolic blood pressure, which is the pressure when the heart is in relaxation. Next slide. So how do we classify hypertension? So if an individual has had the blood pressure taken on different occasions, and the BP or blood pressure is said to be elevated and sustained, there can be two. We normally classify it as into two: the primary and then the secondary. The primary, sometimes called the essential hypertension, is the commonest form of high blood pressure. The cause is poorly understood, and over 90% of cases of high blood pressure fall into this group, and it develops gradually over time. And usually individuals who have this usually have multiple risk factors. The second form is the secondary hypertension. Secondary in the sense that it is due to another reason. Most often, the patients are usually younger. It contributes to less than 5% of the high blood pressure we see, and there is usually a specific reason for the blood pressure. Most often, the kidney is the culprit, and the onset is usually sudden and often severe, and most often also difficult to treat, and we call it refractory hypertension. Next slide. So the majority of people with hypertension have other risk factors for cardiovascular disease. And this may include abnormal cholesterol, cigarette smoking, diabetes mellitus. They may also have what we call comorbid conditions, so meaning they have other disease conditions that you can find in them. For example, they may have stroke, they may have had myocardial infarction or heart attack. They may also have chronic kidney disease. Sometimes they may have sleep problems, sleep apnea, obstructive sleep apnea, and some other problems. And the presence of any of the following risk factors tends to increase the risk, the cardiovascular risk of an individual who has hypertension. So when we see hypertension, we also look for the other markers. We have to look for the things that coexist with hypertension. We have to look for other risk factors that are there. So in assessment of patient hypertension, it's not just enough to take the blood pressure and record. We do well to the patient if we look out for the other risk factors or comorbidities that the patient may have. Next slide. So hypertension is diagnosed by measuring blood pressure of a person. And there are many devices. Time will fail me to start going through the historical landmarks that has occurred until what we have today. Man has gone through a lot of process in refining the method of blood pressure measurement. And the availability of these devices and knowledge required to use them constitute one of the bottlenecks that prevents us from scaling up comprehensive hypertension programs in our communities. So because if we have all devices in the community, blood pressures will be poorly recorded. If you have individuals who are not trained in blood pressure measurement and how to record and how to manage them, then it becomes difficult to control blood pressure, becomes one of the factors limiting control of blood pressure in the community. Next slide. So there are a lot of devices in the market, but you have to choose the best out of what is available in the market in order to help our patients. So a good blood pressure device should be affordable, meaning that we should be able to buy it in the market. Number two, it should be simple to use. Number three, it should be accurate, that what we intend to measure is what we're actually measuring. And we should be able to validate it, meaning that maybe there's usually a gold standard through which we walk through the process of validation. And then the machine also needs to be durable. It's not something you use. It's not like cotton and wool and spirit that you use and dispose. It should be durable, that it can be used for repeated blood pressure measurement. Next slide, please. So the gold standard in blood pressure measurement is the Mercury devices. This is still seen in most clinics in Africa, but in the developed world, these devices are no more in use. The problem with it is the potential of risk of spillage, that mercury can spill, and then this is toxic to the environment and also to man. The other problem with it is that you need a trained personnel to do that. Somebody who can be able to use the stethoscope, whose hearing ability is also good. And also, the process of measuring blood pressure needs to have, your eyes must be in good condition. And the process, in that case, most often people go for terminal digits. Most often they say blood pressure is 125 over 80, or, a lot of a problem with that. Unlike, but we are encouraged that blood pressure measurement should be precise. It's not something that you approximate. So the tendency for approximation is high with Mercury devices and the ones we are going to see later. Next, please. So this is Aneroid speak. I'm sure many of us have seen this in our clinics. It's not as precise as the Mercury device. Also requires training and experienced personnel to operate it. It has tendency for observer bias as well as terminal, just like the Mercury for approximation of digits. Because it uses a bellow and lever system, this has tendency to wear and tear with use. So it doesn't last long. That's just a summary. And also the major other problem there is that it requires regular calibration, and this should be done every 6 months. And the device for calibration is not easily available in our environment. And so it's not really a good device for our system. So we would have the automated blood pressure machine. The advantage of this is that it requires less training than other devices. Many people can use it for their home blood pressure measurement, or even if you need training, you need minimal training for people to use it. Does not require the interpretation of sounds as we found as in the other devices. And also there's no need for calibration. And the shortfall here is that it requires power source such as battery, electricity, and solar in order to use it. Next, please. So this is a summary looking at the qualities of different machines, and you see where they are doing well and where they are not doing well. The gold standard, observer skill required, terminal digits. These are some of the things we have spoken. You can see that the digital machines have a lot of advantage, especially in resource poor setting as where you don't have nurses and doctors in the remote and parts of our country. Next slide, please. So we have gone through this before. These are some of the advantages of the digital speak. I don't want to repeat that again. Let's move on. Next slide. So if we want to measure blood pressure, this is a recommendation from international guideline. One, we need a quiet room, which is comfortable and it's not hot, like many of our clinics, especially in hot weather. No smoking or coffee, at least for 30 minutes before the procedure. Individual must empty the bladder and then relax for at least 3 to 5 minutes before the blood pressure is taken. And it is recommended that we take at least 3 blood pressure measurements at an interval of 1 minute. And then the average of the last 2 is what is usually used. So patient is in a sitting position, the back is rested, he should not talk in between the measurements, and the cuff is well fitted, appropriate cuff, I must say. It shouldn't be too small and it shouldn't be too large because if it's too small, you get the wrong reading. If it is too large also. And then the arm is bare and resting, and the mid arm should be at the level of the heart. In addition, the feet of the individual must be on the floor and not crossed. So this is the standard way of measuring blood pressure. So in a summary, I've tried to introduce us to the concept of blood pressure. And I've said that when we have persistently elevated blood pressure, we say an individual has hypertension. We said that hypertension can be primary or secondary primary. We call it idiopathic. We don't know why. It's one of the ways we hide our ignorance. It's also called essential because it's not known. Then you have the secondary, which constitutes about less than 10% of the hypertension. And in this case, the cause is usually known. And in this environment, the kidney is usually the culprit. And I also talked about cardiovascular risk factors, as well as concept of comorbidities in hypertension. We also walked through the different types of blood pressure machines. Talked about the Mercury and then the Aneroid, as well as the digital. And we said that in busy clinics and in communities where you don't have access to people who can use the stethoscope to measure blood pressure, a digital BP machine is well suited. And we said the only problem there is the power. Once we have source of power like battery or NEPA or solar, you can easily do the blood pressure. And then we talked about how blood pressure should be measured, the proper sitting position, where the arm's supposed to be, what we should do at the time of blood pressure measurement. Thank you very much for listening.
Thank you so much, sir. And so we'll give the floor to Dr. Ojji. Please go on, sir.
All right. Thank you very much, Dr. Ogah, for laying a very good foundation. Dr. Ogah has been my friend, for over 27 years. We are classmates in medical school. He's the president of Nigerian Cardiac Society. So well done, Dr. Ogah. And also, mDoc, thanks for the invitation, led by Dara. Thanks for the good work, and also for the good work Northwestern University is doing in terms of trying to establish a system for hypertension care in Nigeria. So welcome everyone, and so we continue. Yeah. So like I said, I was taking up where Dr. Ogah stopped, so I will be doing some deeper dive as regards measurement of blood pressure using the digital machine. And before you measure the blood pressure of the patient, please, the patient should relax. So, and one of the ways you make the patient to relax is to explain the procedure, what you are going to do to the patient. So don't just grab the hand of the patient. Immediately the patient comes to your clinic and then you measure the blood pressure. Patient should relax, engage the patient possibly in some sort of discussions and calm the patient down. So patient should be seated quietly for about 3 to 5 minutes before the measurement. One important thing is that you use the correct size cuff and bladder. Most times we have a cuff size that fits about 95% of the population, but some people might have very thin arm, and then they will need a very small cuff, what we call the small size cuff. And there are some people that are quite on the big side, and they will need a larger cuff. So it's very, very important that the right cuff size should be used. Like Dr. Ogah said earlier, if you use a cuff that is too tight, you have a very high value or higher value than you expected to. And if you use a cuff that is bigger, than the arm of the patient, then you are going to also be having a lower value compared to what obtains for that individual. So measure blood pressure while patient is in sitting position. One important thing is that patient should be well seated, like we saw in that diagram, and there should be a backrest for the patient, and the legs should be on the feet, on the floor, and also not crossed. Ideally, both arms, so ideally that's what we do, both arms should be used in measuring blood pressure, and subsequently you use the arm that has a higher value, because for each individual, the two blood pressure on both arms are not the same. One is higher. Some people think that it should be higher on the left because the heart is on the left, but it's not true. It's not. That's just a myth. It's not so. People have what we call a dominant part of your body, and the blood pressure is normally higher on the dominant part. It can be on the left, it can be on the right. And one thing again is that if the blood pressure is elevated, so we're looking at 140 millimeters of mercury systolic, that is the upper one, and 90 millimeters of mercury diastolic. It's advised that maybe you take two measurements about 1 to 2 minutes apart. And blood pressure reading should always indicate, which arm you are using. That is the right practice. So as much as possible to. Sometimes in the primary care, we don't tend to emphasize on some of these so that they don't get confused. But as much as possible on the folder of the patient, on the card of the patient, it's always good to indicate the arm that has a higher blood pressure, and that should be used subsequently. Next slide, please. Like Dr. Ogah mentioned earlier, for the manual, using the mercury sphygmomanometer, it is more cumbersome. Remember that the digital is best for primary care and non-physician healthcare workers. But the same action you take in terms of doing an introduction, what you want to do, you must get a consent and explain to the patient. In the same way also, you have to allow the patient to rest for 3 minutes, if seated, 1 minute if standing, then ensure the upper arm is supported at heart level, just like we saw in the diagram. One thing you must always ensure is that tight or restrictive clothing is removed. Our patients should be on light clothing, clothing that can easily be rolled up as much as possible. And ideally, we don't want you to take blood pressure over the clothes, except it's very light clothes, because if you take blood pressure over the patient clothing, likely you get a higher value. And check the cuff that is the correct size. I mentioned that before. And you should wrap around the arm with the center of the bladder, covering the brachial artery. So we saw that in the diagram. Make sure that the bladder actually covers the position of the brachial artery for those that are medical, paramedical here. Next slide. So we know about the mercury is you have to be more detailed, you have to be more trained. That is one shortfall of the mercury sphygmomanometer, what we call the manual. So you deflate cuff completely and wait 15, 30 seconds before continuing, inflate cuff to a pressure. So normally you make sure you inflate, about 30 millimeters higher. Then after that, you then start coming down. And normally when you hear this first sound, what we call the Korokov sound 1, that we are equivalent to the systolic, and then you keep on. And when the sound disappears, that is equivalent to the lower blood pressure value or diastolic. And then you fully deflate. It's always better to fully deflate. If you don't fully deflate, then you will be reducing the lifespan of that machine. Next slide. So these are talking about blood pressure cuffs. So the bladder inside the sphygmomanometer cuff should be the correct size, just like we said before. And I said that most people, we require the standard bladder, which is approximately 12 centimeters in width and 25 centimeters long. However, like I said earlier, those that are obese will require larger bladder. And other thing you must take note of is that the bladder which should be approximately 40% of the circumference of the arm. That is one way, we can estimate the type of bladder that will be adequate or appropriate for a patient. And the bladder should be long enough to wrap 80% to 100% around the arm. But what is done with the digital machines is that they have 3 sets of bladders, and there's the small one, for patients that are on the thin side, very thin side. Then there is the average, which about 95% of patients use, and that's what we call the large cuff. Next slide. One thing about blood pressure is that it's one of the measurements that is most taken all over the world. And it's also been noted that it's one of the measurements most inaccurately, taken, all over the world. So most people will say it's not blood pressure. but there must be a methodology, and there must be quality control, especially coming to the machines and how you take the blood pressure. The blood pressure measuring device must be known to be accurate. That is one thing. And that is one of the backside of the Aneroid, because you need to calibrate, recalibrate. Also for the mercury sphygmomanometer. But for the digital, especially if they are validated, and there are sites for validation, you can Google that, sites for that mention validated digital machines. You can see that. So if it is validated, then you can go to sleep and know that that machine, is very good. Now, the other thing about the manual, especially the mercury, that maintenance and calibration is needed. Most time the mercury leak is a problem. So the columns, start decreasing. And by that time, you cannot get the most appropriate value. And like Ogah said before, patient should not take caffeinated drink. Even Coca-Cola, we say as much as possible, prevent that tea or some tea, theophylline 30 minutes before the blood pressure is measured. Yes, next slide. So this is staging of hypertension, which is one of the myths. I remember this was one of the questions, that came out on the quiz. So why is blood pressure stage? How do we grade blood pressure in current medicine? And this is from the European Society of Hypertension. Also, the World Health Organization has this, and Nigeria Hypertension Society also have a guideline, and this is also there in the guideline. So that's what we call optimal. That is the blood pressure we should be aiming at. Everybody's blood pressure should be less than 120 millimeters of mercury systolic and less than 80 millimeters mercury diastolic. This is the best. We call it optimal blood pressure. Then for normal blood pressure is systolic of 130 millimeters of mercury, as you can see, diastolic of 85. Then you can see grade 1, you can see grade 2. One of our questions was, what grade of hypertension is it? At grade 1, 140 to 159 is grade 1, and that's systolic blood pressure, and 90 to 99, at diastolic blood. You can see grade 2, grade 3. By the time it is grade 3, that is systolic of 180 millimeters of mercury and above, and diastolic of 110 millimeters of mercury and above. We call it severe hypertension. And there is also what we call isolated systolic hypertension, which can be quite difficult to treat sometimes. And we see it more in elderly patients and in some conditions, like when patients are anemic, when patients have thyrotoxicosis. In this case, the systolic blood pressure is 140 millimeters of mercury and above, but the diastolic is less than 90. So, for example, you can have an elderly patient coming down with a systolic blood pressure of 180 and diastolic blood pressure of 70 millimeters of mercury. And that is what we call isolated systolic hypertension. There can also be isolated diastolic hypertension, which is not as common as isolated systolic. And for the medical people and paramedical, one of the causes of isolated diastolic is hypothyroidism, where the thyroid glands are hypofunctioning. Next slide. So the other types, we must take note of white coat hypertension. When a patient comes to the clinic and because of the anxiety sees the white coat of the doctor or doctors or healthcare workers that are not too friendly, or even if they are quite friendly, the anxiety of waiting for an healthcare practitioner, a physician, can make the blood pressure to rise. But it's been noted that this is innocuous. So if a patient keeps on having white coat hypertension, it means that likely in later life is going to have established hypertension, persistently elevated blood pressure. There's a group we call resistant hypertension, whereby we have used the conventional medications, including a diuretic. And the conventional medications are long-acting calcium channel blockers like amlodipine, what we call the RAS blockers like angiotensin converting enzyme inhibitors and angiotensin receptor blockers. Examples are like lisinopril, perindopril. Angiotensin receptor blocker are things like temisatan, vasatan, losartan. You have used them in maximum doses, including a diuretic like hydrochlorothiazide or indapamide, and you have excluded other reasons for false results. For example, the machine, you know that the machine is working very well. You know the patient is not consuming coffee. You know the lifestyle is well taken care of, and the blood pressure is still elevated. It's not controlled persistently of 140 millimeters of mercury systolic and or 90 millimeters of mercury and above diastolic, then you say that person has a resistant hypertension. And there is a way those patients are treated. Those patients are not patients for primary care. They are referred to secondary care or tertiary care to see the experts. Next slide, please. So what are the therapeutic implications? Because this is what the meat of this second part, of this discourse or this presentation. Now, one important thing we must take note of is that all adults, to adults 18 years and above, should have their blood pressure, checked regularly. We say that at least once or twice a year. Then if such adults have family history, a mother, a father, a first-degree relative, a brother, a sister having it, we say check it more regularly. Even if as you check it, it's still normal, keep on checking regularly, 2 to 3 times or 4 times, So all adults should be screened. And adulthood in Nigeria, like we know, starts from 18 years. Now, if blood pressure is elevated, like Ogah was saying, when he showed the first slide, it has to be persistently elevated. So sometimes you don't just use one-off blood pressure. If the blood pressure is like 142/92, you won't just say, okay, for the first time, you won't just go on and try to treat the patient. That's the type of blood pressure you have to repeat 1, 2, 3 times. And if it's persistently elevated, then the patient can be deemed to be hypertensive, and such a patient can be started on medication. Now, by the time you're having blood pressure of 160 millimeters of mercury and above, those are patients you want to repeat their blood pressure earlier. In fact, maybe on that clinic visit, you can say, first of all, rest, it can be a 2-3 hours and repeat it. And if, for example, you're having a blood pressure of 170/100, it's better you repeat it then, because if you leave out that patient to go home, that patient might come back with a stroke or a complication. So those are the type of patient you want to repeat the blood pressure earlier. Now, for patients that have blood pressure of 130 to 139 systolic, institute lifestyle systolic, and the same for those that have diastolic blood pressure of 80 to 99. If that is, they don't have any cardiovascular risk factor. So they don't have diabetes, they don't have high cholesterol. If they have diabetes, they have high cholesterol, they have to be referred from the primary care so that there can be good stratification. There can be holistic a review of that patient, and to know if the patient should start on medication and which type of medication that patient should start on. But one important thing is that if a patient has a blood pressure, that it persistently have a blood pressure that systolic blood pressure 140 millimeters of mercury and above, and or diastolic blood pressure of 90 millimeters and above, then you confirm the diagnosis of hypertension, and ideally such a patient should be started on medication. Next slide. So why do we treat blood pressure? And this was one of the questions that also came out. So the main reason why we treat is to reduce damage to what we call the target organs. And the target organs include the heart. So a patient can have heart failure or have a heart attack or what we call coronary artery disease or myocardial infarction from hypertension, especially when other risk factors like diabetes, smoking, and high cholesterol occur with hypertension. Patient can have kidney failure, what we call chronic kidney disease or chronic kidney insufficiency. The brain can be damaged with stroke. Patient can have stroke, can give rise to dementia because of little injury to the brain at the end. And the eyes also, there's what we call hypertensive retinopathy, where the eyes are affected. So we treat to protect the target organ, want to lower cardiovascular risk. Because if a patient has high blood pressure and that high blood pressure has predisposed to a higher cardiovascular risk, want to lower cardiovascular and renal complications that will come, from high blood pressure. They want to lower mortality. And it is known today that high blood pressure is the #1 risk factor for poor health all over the world, and also for mortality all over the world. Through was stroke, heart failure, chronic kidney disease, and so on and so forth. Next slide. So how do we treat at the primary care level, which is our focus here? How do we treat? Now, luckily, one thing that has happened to Nigeria is in the last 5 to 6 years or so, there's been some emphasis on non-communicable diseases, even at the primary care level. Before this time, the focus were on infectious diseases, treat malaria, HIV, then also on antenatal care, and vaccination, and so on and so forth. So treatment of hypertension is now being instituted at the primary care, and that is one of the work we are doing in 60 primary healthcare centers in Abuja, FCT Abuja, and there's also a similar work, but really in HIV patients in Uyo, that is Akwa Ibom State. Next slide. So there's a simplified protocol. This protocol was developed in 2019, and it was developed in collaboration with the Federal Ministry of Health, the WHO, Nigerian Hypertension Society, Nigerian Cadre Society, the pharmacists were there, non-physician healthcare workers, community health workers, community health officers were involved, and pharmacy technicians also came. And at the end, this protocol, which is a simplified protocol, and what is the approach to using this protocol? If you have a patient that the blood pressure systolic is persistently 140 millimeters of mercury and above, and diastolic 90 millimeters of mercury and above, now you start amlodipine, 5 milligrams. And why amlodipine? Amlodipine because it is the most prescribed antihypertensive. It is more efficacious than diuretics, even in Black patients. And that is what we have shown in our study. It is what we call metabolically neutral. It causes less urination. It has less side effects compared to diuretics. So we start with amlodipine. Now, if after 1 month, the blood pressure is not controlled, then you say add losartan. Losartan is angiotensin receptor blocker. And they avoided angiotensin converting enzyme inhibitor like lisinopril and perindopril because of the side effect of dry cough and angioneurysma. Because in primary care, we want to, as much as possible, prevent any side as much as possible. Because you can imagine what happens if you are using lisinopril and one patient has angioneurysma or swollen lips. That news can spread fast in the community, and it can dissuade others from coming in. So we are using agents that have the minimal side effect profile as much as possible. After another 1 month, if the blood pressure is not controlled, then you double amlodipine 10 milligrams and losartan 100 milligrams. Many people will say, why did you not double the amlodipine initially and make it 10 milligrams? No, that is not the approach to management of hypertension these days. We use multiple agents to complement each other, to reduce overall side effects, and to improve efficacy. There's what we call synergistic property, whereby 2 drugs from different classes add together and become more efficacious than increasing one pharmacological agent to maximum dose. By the time you use amlodipine alone, the side effects 10 milligrams will be more compared to if you are using 5 milligrams. So that is why. Then, if after that there is no control, then you can add a thiazide. You can either add hydrochlorothiazide, 25 milligrams, or you can add moderatic, half moderatic. We don't use full dose of moderatic because full dose of moderatic contains 50 milligrams of hydrochlorothiazide with another 5 milligrams of amiloride. It will cause excessive urination and dehydration. That is when the patient is coming with 140 millimeters of mercury and above, and 90 millimeters, but less than 160 systolic millimeters of mercury above, and less than 100 millimeters of mercury above. So when the patient comes in at 160 and above systolic, or and diastolic of 100 and above, then you are going to start from stage 2. So you are treating ab initio with amlodipine 5 milligrams and losartan 50 milligrams. Next slide. So this is just what I've explained. If blood pressure persistently, elevated, systolic or 140 milligrams and above diastolic, but it's less than 160 over 100, start amlodipine 5 milligrams. And I've told you the rationale for using amlodipine, above thiazide. And after 1 month, you add losartan. And I told you it's preferred over ACE inhibitor like lisinopril, perindopril because of dry cough and angioedema. And that goes on. And that now, if the blood pressure now is 180 millimeters of mercury above and 110 millimeters of mercury above, we say commence amlodipine 10 milligrams, losartan 100 hydrochlorothiazide, and refer patient immediately. We don't treat severe hypertension at the primary care level. That is left for the secondary care level and also at the tertiary care level. Next slide. So these are some strong points for the hypertension treatment protocol. And by the way, let me tell you that WHO recognizes this Nigerian hypertension protocol, simplified protocol. And if you go to their website, they have used it as an example of a good protocol that can be used at the primary care level. So contemporary classes of medication, what I mean by that, we are using the current medications in the treatment of hypertension. So you cannot be faulted anywhere. Now, long-acting calcium channel blocker, amlodipine, so you can confidently give this medication once a day. In the modern day management of hypertension, we want the medication to be given once a day, as much, because you will improve compliance, you will improve adherence, to treatment. Now, renin-angiotensin-aldosterone system blocker. So this is very, very important if you want to protect the end organ. Thiazide diuretic is one that is recommended globally. Long half-life, so you need daily dosing. It's efficacious in Black African. We have shown this in our study, that this combination are efficacious in Black African. Minimal side effect profile, that's one of it. Emphasis on combination therapy. One thing about hypertension management now is that combination therapy, because most patients, over 95% of them in our population, will not get their blood pressure to go on one medication. Then encouraging single pill combination, then simple, very, very simple in application. Next slide. So in summary, what we've tried to do at this second stage is to maybe just do a deeper dive on measuring blood pressure using a digital machine, which is simpler, and using the manual machine. And also we've looked at categorizing hypertension, blood pressure. If you have your blood pressure value, what does it translate to? What is optimal blood pressure? What is suboptimal blood pressure? And we looked at optimal, that blood pressure of systolic less than 120 millimeters of mercury and diastolic less than 80 millimeters of mercury. I'm sure someone will ask, how low do you go? People have asked those questions. How low do you go? Yes, we say around 170, 160 is okay, provided the person is not dizzy, But some people even have lower blood pressure than that, and they are created well that way. They are stable. We don't have any issue, about that. Then also, we've tried also to look at what is the approach treating the patient at the primary care level using our simplified hypertension protocol, which has been recognized by WHO, and we've seen the advantages, of using this protocol at the primary care level. And also being a caution that there is a limit in which hypertension can be treated at primary care level. For patients that have heart failure already, have chronic kidney disease, have a stroke, they are not treated at primary care level. If we have severely elevated blood pressure, systolic blood pressure 180 millimeters of mercury and above, and diastolic blood pressure of 110 millimeters of mercury and above, those are not patients for primary care. They are referred to secondary care or to tertiary care, at least to a specialist. So thank you very much.
Thank you so much, Dr. Ojji. Thank you so much, Dr. Ogah. That was a very rich deep dive into hypertension essentials.